You know, you have to. It's an all-day thing because, yeah, because there's the lake, and you had to, and there's the mountain, but you have to go around the lake to get to that, and the roads aren't necessarily paved. And some of the, you know, I was so glad for my truck. You know, you had to literally
moving, Mike.
Administrative burden related to all these things, where
Guess that answer's yes. Did you see my email? I said, you didn't
Good morning, everyone. Thank you very much for joining us to discuss a critically important topic in Delaware. We want to thank Delaware Tech for hosting. I'm State Senator Brian Townsend, and I'll be moderating today's event. We want to move pretty quickly to get to the heart of what we want to talk about, both the presentation from two very distinguished individuals from Massachusetts, but also the Q&A, which we hope will involve difficult, important, dynamic questions, particularly with regard to how we can take lessons learned from other states, especially Massachusetts, and apply it here in Delaware as we tackle this very, very important issue. With the blessing of Dr. Walker, I want to note from the outset, for those of you who follow along closely with legislative results in Dover, I actually did not vote for the joint resolution that has brought us to today. And as the chair of the Senate Health Committee, that was a bit of a surprise to some people. I had really been pushing for, out of the gate, a formal stakeholder process with a task force type model, but for a variety of reasons, including the nice budget experience that we all went through this year, that's not exactly the product that had come out. I mention that only because some people who are involved in the process kind of asked me curiously, especially as they heard me talk favorably about the importance of benchmarking and the importance of cost containment. But wait a second, you voted against it. It was very much more procedural and thinking that there's a different way to tackle it. And as Senator Moore, I'm sure, knows, as a legislator, you hate to vote no for something, the intent of which you support and the goals of which you support. It often results in a disclaimer like the one I'm finishing right now. That all being said, again, I think that there are a lot of important topics in Delaware to tackle into 2018 and beyond, and one of the most important is this very issue, not only because of the importance of health and wellness, obviously, and the importance of doing so efficiently, but also the inequities in our healthcare system and the weight that it ends up being around our ankles as we want to tackle many, many other issues. Just the fiscal implications alone of this issue really hold back so much other progress in Delaware, and so it really is an important topic to tackle. And let that be a segue into our first speaker. I think she needs no introduction, but Dr. Kara Odom Walker is the DHSS Secretary and came to us at the start of the Carney administration with a background in family medicine, but also a background in the use of data for pushing progress in healthcare. So really a great combination of the perspectives that we need to achieve the progress that we have to achieve in Delaware in coordination with the many, many stakeholders, so many of whom are in the room today. Again, we thank you very much for that. Both for Dr. Walker as well as for our two distinguished out-of-state guests, I won't read the exact biographies that I think many of you have picked up from outside and have been flashing on the screen for quite some time. I always find at events that it's kind of funny to just read verbatim the biographies. But that being said, they often are carefully crafted so people understand the specific experiences of the individuals and why it's relevant that they're here. And again, I think for Dr. Walker, it's critical to have someone in this position who has both the practice experience of being a physician, but also the use of data, which we've got to find more and more ways of interjecting into healthcare decision making so we can do as good a job as possible. So on the fly, that's my version of her introduction. And Dr. Walker, please very much kick us off.
Someone's going to magically make my slides appear. But we're really excited to have everyone here today. It's a great way to start off our Monday morning with a little discussion of healthcare. And many of you have heard us talk about the context for why we're taking on looking at paying for care in our state in a different way, but also what are those principles that are really essential for us as a state to embrace? And there have been many conversations, which I'm looking at across the room. So many of you have been part of these conversations, whether they were with our state innovation work, whether it's with the State Employee Benefits Committee, whether it's at your own local institutions. How do we pay for care, and how do we organize ourselves to produce the best population health outcomes that we possibly can? You know, we have a tremendous opportunity, and certainly as we track trends over time, we have seen many states around us take on this issue in different ways. This is our chance to own it, and our chance as a state to take this on. We are on Facebook Live today, so if you're on Facebook, feel free to follow Delaware DHSS. If you tweet, feel free to tweet at Delaware_DHSS and use the hashtag OurHealthDE. I'm going to just share a bit about how these principles come together before we have this conversation about how we want to create the legislative and regulatory framework to allow us to do this. We are trying to get to a place where payment aligns with value, right? We know that in healthcare, we're paying often for visits and volume, and we're not necessarily paying for coordination or for things that we know make sense or make us healthier. We're trying, and there are so many places that are trying to make this happen, but we certainly have not figured out how to align all of these elements yet. And so I think the road that we want to take, everyone likes having a road and some signs to know if we're getting there on your trip. But we really want to get to a place where we're supporting the elements that we all think are important, right? What we want for our mom or our brother or our, little ones. We want to support patient-centered and coordinated care. We want to make sure that the health workforce and the infrastructure that we have, whether it's IT infrastructure, whether there are actual locations, whether it's telehealth, we want to make sure that infrastructure is in place so that we can support what patients really need. We also know that the little green dot, looking at the health of special populations, is really critical, because some of those special populations, whether it's those with chronic conditions or those with disabilities, tend to drive a lot of healthcare costs and some of the outcomes that are less desirable. So how can we do that in a way that engages communities, engages every individual to participate in that conversation? And how do we do that in a way that is supported by both the payment and the tools that we have to drive things into better care? We also, as the orange little dot marker says, we want data-driven performance. How do we get to a place where we know the cost of care and we also know the quality of care? That allows us to have these transparent conversations about where we're going, if we're heading in the right direction. And I think this is a really critical part, why the benchmark allows us that flexibility to say, we want to set a target, we want to contain costs, because the increasing costs in our state are really pushing out other things in our budget, like education and infrastructure and other places where we really need to invest dollars and think about things differently. But certainly healthcare costs are driving that out. We've gotten to a place where we're third highest per capita in costs. We know that we need a little bit more information about what does that really mean? What is driving those costs? What makes us so different and unique? And what gives us the opportunity to have a conversation around quality and cost where we're really paying for value? So we've had a lot of conversations with many of you in this room around the benchmark. The benchmark is really a framework to say we want to set a target and we want to achieve that target and cost, but underneath of it are all of these other important elements that we really need to flesh out. And so this is just setting the stage, and we're going to have continued conversations around what are the essential elements that we need to have beneath the benchmark that allow us to really organize that payment and that value. So next, I've reiterated this because I think it is really important to remember why we're talking about this right now. And when you're really at a place where our per capita healthcare costs are more than 25% above the US average, it's time to just take a look, take a deep dive into why we're going in that direction. And many of you have seen this cost curve escalate that we expect spending to double by 2025. If we don't start to change that, we really are going to be in a situation where we're back at it again every year, trying to figure out the budget, right? Trying to figure out the state's budget, trying to figure out where to make cuts, and And some of those cuts are really hard. You start to think about the choices that we're making year over year, and when it's a lot of it is just how we're paying for healthcare. When Delaware healthcare costs consume at least 30% of the state budget, we really do need to think about things in a different way. And so this is why the benchmark is important. It's a convening principle, and there are many elements that will have to be embedded in that plan, but we'll get there together. This graph, again, context, because some of you may not have seen it, but I think I show it at every one of these forums, so if you haven't seen it, ta-da! We're that little yellow bar. We really are third highest per capita. We're only Alaska and Massachusetts are higher. And Massachusetts is making progress. So are we going up and they're going down? I don't know, but I think that's something we'll hear about maybe a little bit later. It is just, again, this convening principle that we need to think about how we're doing and where our levers are. When you think about the benchmark, I think this graphic is a nice way to depict it. If you like pictures, I like pictures and numbers, but hey. We really do want to start to say, what is our target as a state? If our state's economy is growing at something like 3%, or our state revenue is growing at 2%, what do we want to use as that match? Do we want to set the target arbitrarily from another entity who says, okay, independent group has said our healthcare costs should grow at X%. I don't know what that percent is, and that's why we've showed these different levels. But it is a chance for us to say, at some point, we have to just put that target in place, set a goal for ourselves, and see where we can work within that budget. So this is the essence of the healthcare benchmark, and we're going to continue to have dialogue around how do you get to those targets, those bars, those lines that you see here. We also know that when you look at overall health rankings or quality indicators, for whatever reason, we're sicker than those around us. Our population is older, it's aging faster. If you look at healthcare rankings, we tend to be sicker than many average states. We're something like 31st according to America's health rankings. And that's a composite score that looks at many factors. It includes things like racial and ethnic diversity and disparities issues that emerge, like infant mortality rates and cancer rates. But what it does remind us all is that we can do more. We can do more around population health. We can do more when we're thinking about certain high-risk populations. And this is, again, this convening principle that if we're paying a lot, maybe we can push a little bit more and try to get to a place where we're actually getting better health out of it too. So these are the opportunities and threats that we have. We know that our state, again, is unique as is every state in many ways, but the first state is also unique in that we purchase healthcare for a greater share of the population than most other states. And so if you start to think about state purchasing power, this term that's used to say, maybe we could use that to negotiate, maybe we could use that to design something that's particularly suited to us. We also know that we have made a lot of progress in learning about what it means to pay for value. And there are many examples. There are examples that people in this room, I hope, will share when we start to have the dialogue. Because we're getting there, but we have more to do. About 30% of our providers are in some kind of value-based arrangement, but we probably aren't yet pushing that bar forward as other places have done. It's mostly upside risk. You're mostly getting a little bit back if you meet certain metrics. We probably want to get to a place where we're also having some downside risk, meaning that if you haven't met that goal, there's some kind of penalty for not achieving those targets. So we might need to start thinking about what that means. How can we accelerate the pace of adoption? Is there something we can do to help people along, support that transition, but also allow everyone to learn as you're learning about value? There are key objectives when we're looking about moving in this direction, and I think the essence of anything that we take on will be that we need to give Delawareans choice and information to make better healthcare decisions. So anything that we do around reorganizing how things fit together or setting targets needs to have these principles in place. We also need to make sure that what we're doing at the neighborhood level, within institutions, within hospitals, needs to reinforce these healthy choices. And then finally, we also need to make sure that we're supporting primary care infrastructure so that allows for improvement, allows for better coordination, allows for a bottom tier that focuses on things like wellness and prevention, because we know that those things matter, and we know that that is something that is important for long-term health and outcomes. So there are several strategies I'm going to go through at a high level. The first of these strategies is really key. Obviously, we want to talk about improving healthcare quality and cost. And this value-based framework is essential to figuring out what you do to actually pay for that care. It's also essential when you start to talk about what are the systems, whether you call them a patient-centered medical home or some kind of accountable care organization or or other kinds of coordination models that are out there. You really need to figure out how you're putting the patient experience, quality, and cost into this framework. We also want to focus on this third bullet, which is reducing unnecessary and inappropriate care. I'm a family doc. I know for sure there are lots of things that we're doing in an everyday visit that sometimes aren't evidence-based, right? You do them because they're normal, they're practice culture. You just reflexively have done it because of the way you train. But we also know that we're starting to get more evidence, and we're starting to know a lot more about what's appropriate and what really is based on sound evidence, what's based on guidelines that are out there. So if we can start to figure out how to capture that up to 50% of healthcare costs that may be waste, quote unquote, or unnecessary, maybe that is a chance for the healthcare community to come together and say, if we create these feedback loops in an ongoing way, there may be a way to capture some of that challenge that every healthcare institution and every provider is facing. We also want to get to strategy 2, which is paying for value, getting away from paying for a visit, paying for a stop at the emergency room, paying for an individual encounter, and getting to a place where we're talking about how you pay for the fact that someone has a better diabetes outcome than they used to, or how their high blood pressure is potentially lowered. One of the ways to do that is, at the first step, is to set this healthcare spending benchmark, and then beneath it, figure out how you want to actually reorient costs towards value. And that requires a lot of different levers. Some states, as you'll hear later, are thinking about how you look at managed care organization contracts, how you embed some of these thresholds, some of this value into individual contracts. But there are many models out there. Some are doing this through what we call accountable care organizations, how you pay at the larger level and then allow others to come in as subcontractors to really allow paying for value to matter and to work. Because you want to share risk. You want to share the opportunity to both gain if you meet these thresholds, but you also want to be able to share the risk with those who are making decisions every day. Strategy 3 is also critical. You have to support patient-centered coordinated care. We know that there's a lot of opportunity to better coordinate services. Many people come to us and say, could you just help make sure that my providers know my information? Certainly, Delaware Health Information Network has made tremendous strides and is a tremendous investment in making that work on a technology side. But some of it is, how do we make that work in other settings? How do we make it work for that family who's struggling with addiction, or that family who has someone with disabilities and their family is trying to put together all the providers who come and support them in their needs? So could we use this approach that others have said, where you have all payers come together in an accountable care organization to facilitate the integration of services and create a foundation of patient-centered medical homes? And then can you also create some new ways to reimburse for services in safety net? I mean, we want to support our most vulnerable, and we need to make sure we're paying for that in a way that is well coordinated and really focused on the right population health outcomes. Strategy 4, we also need to make sure that we have the provider, workforce, and healthcare infrastructure needs in place. And a big part of what the federal waiver system has done in the past is allow states to say, we want to go down this pathway. Can you please also throw in some money so that delivery systems can have incentives to invest in the infrastructure that's needed to actually do practice transformation, to redesign how we do our workflows? That requires money and investment, and is not something we should just put on the backs of providers or systems. So we need to make sure that we're not only thinking about the long-term trajectory of our primary care workforce, particularly in a state where we don't have a medical school. We really need to figure out, what does that mean? But then we also need to expand beyond just physicians physicians. We need to think about dental care, behavioral health, and other health professionals. It's really essential to think about those other workers who make the care coordination essential, community health workers and others who are paraprofessionals and really essential to making sure the healthcare team works effectively. We also have a lot changing in our state, as we've seen in other places, where we need to reflect the racial and ethnic diversity of the population at large that we're trying to serve, and those who are experiencing those disparities over time are definitely at times the place where we need to focus our efforts. And so if we can start to use this as a chance to invest in that racial and ethnic diversity of the workforce, there are many efforts going on in our state right now to support that, but we need to continue pushing. We also need to prepare for the fact that our safety net providers have increased needs right now. For all of you who are watching the federal changes that potentially could come to states, whether it's this week or whenever, we all need to prepare for the fact we may have more people who are uninsured and trying to navigate systems. We need to make sure we're focusing on those opportunities to get people into care, to think about prevention and access. And maybe this is, again, this part where we need to figure out how to get people into care when it's needed, whether they have insurance or not. We will certainly also need to move forward with technology, whether that's investing in telehealth, whether it's investing in phone calls or video medicine. There are so many opportunities to better coordinate services and, again, invest in that technology that's needed. And then we're also doing some of this work now that we keep pushing around investing in provider readiness. There are data analytics, there are technologies that need to be in place for people to understand whether they're, as a provider, they are actually making progress. If you're being measured for outcomes, you need to be able to, in real time, know if you're getting there or if you're way off. And so those feedback loops are really essential, but you have to have the investment infrastructure in place. Strategy 5, again, we have to focus on special populations, particularly in our state, and figuring out how to strengthen that capacity and promote health equity for disabilities is essential. How we support families who are trying to make sure that supports are aligned. We also have a huge opportunity to focus on maternal and child health, where infant mortality is a big part of our challenge as a state in health rankings. So is that, again, something that we can continue to deploy evidence-based strategies like nurse home visits to those who are most at risk. We also know that we're dealing with an epidemic of violence in the city of Wilmington, so can we embed these principles of trauma-informed systems of care that can also better support our outcomes and opportunities to integrate mental health and physical health. And then finally, again, this is, well, all of these principles are called out in many places, but certainly in the governor's action plan, where he really called out this focus to look at prison reentry populations and how we can better support their needs. And we're trying to figure out how those transitions in care can be more integrated from a health lens. So this is one additional special population need. And I'm sure there are others that will emerge, and I hope that through having these conversations, more of you will say, you know, we need to focus on this, and this needs to be embedded in the overarching plan. Strategy 6, engage communities. We certainly want to leverage the strengths of communities and put the decisions and the feedback loops at the community level as much as possible and improve the opportunities to look at community-based wellness initiatives. Even more, we want to look at population health metrics and create these data-driven approaches to allow community health workers to have the information they need to do door-to-door visits or community screenings or set up appointments so that people know what can happen when you really engage everyone in their health care. So this is just another part of it. Much of this work is already existing. We just need to strengthen the resources that are currently in place. Strategy 7, we need data. As you heard Senator Townsend say, I support the need for data that we believe, that we trust, that we know is reliable, and that's going to be a big investment. We already have some of the infrastructure in place, but making that real is critical. So can we use this public-private collaborative approach to establish both the quality and cost targets, decide what metrics are really important, what are the quality outcomes we all expect collectively, and how do we get there and monitor that over time. And I think we're going to need to get to a place where any accountable care organization has a methodology that we all agree with, that we can have a common language when we're talking about quality and cost goals. What are we talking about when we have a benchmark? If we have a public hearing about these things, are we all talking about the same expectations? And can all of the payers come together with these total cost of care models that have been effective to say, bring everybody together? It may be a kind of staged approach, but how do you get everyone to say, we believe that this is the total cost for this type of care, and how do we define that? And we also want to make sure that we're not forgetting about the exchange. And the exchange right now certainly is a big opportunity for us in Delaware, but we know that it's challenging. We don't have a lot of competition as a state. So are there ways to bring in additional strategies to strengthen the way that people get coverage in our state? And I think this is going to be really critical. Can you marry what happens in our exchange and Medicare? Can you marry what happens with these accountable care organization models to make sure people have access and have a way to get care across the spectrum of their lifespan? So this success relies on everyone coming to the table. It relies on many outreach groups, many key constituents, the leadership capacity that we already have in the state, and the data and informatics that we already have in existence. But we're going to need to continue to push that dialogue, and we're having as many conversations as we possibly can with groups. I've heard very loud and clear from so many people who have said, this is important, let me know how to help, let's continue to have this dialogue. Oh, but by the way, I want the details, right? So we'll continue to have conversations around what those details are. What will this really look like and feel like? And how does this impact everyone who's sitting around the dinner table and isn't sitting at a summit or a forum? How do we have those conversations as well? Because this is something that impacts everyone, not just those who have insurance who are paid for by the state, but it goes beyond that. And certainly employers and the economic opportunities in our state are limited when healthcare costs are skyrocketing and employers are having trouble getting additional insurance coverage for their employees. So this is just a starting point, but we're looking forward to many more conversations. It certainly has many connected pieces. Our legislature goes back into session in January. We're right now in a stage where we're in the planning and dialogue process. We're looking forward to having a draft report in December about how the benchmark will work. That was called out in HJR 7. And a big part of that is, how do we create some economic models? What's the governance going to look like? How do you actually set the targets? Where do you think we're going to go around developing the different policy options? Because certainly there are a range of policy options that we could consider as a state. We have a large RFP out right now where we're hoping to soon have some additional consultants on board and additional expertise to help guide that economic modeling and that development. But I think this is all part of the dialogue, and we're having as many conversations about what matters to each and every person who may touch this planning process. We need to have stakeholder input. We're looking forward to people sending us comments on Facebook Live and having a public comment process to engage in ongoing conversations. And we've had many people come and say, we want to have a stakeholder group meet around certain issues, or nutrition, or issues relevant to the pharmaceutical industry, or issues relevant to those with chronic disease. If you know of others and those with disabilities who certainly said loud and clear, we need to think about these issues in a unique way. So I hope all of you here and all of you online will continue to say we need to have these conversations and have a way to think about what's critical and what's worked in other places, and what key elements and best practices could be developed here in Delaware. We're going to continue to have summits. This is the third of 5 that's been planned so far, but there will be additional ones. Certainly on October 18th, we're going to have a very geeky one. This is going to be me in my world talking about data analytics and how do you look at the methodology to calculate things like cost and quality. And we could probably spend 3 days on any of these issues, but we're going to at least have an initial conversation. On November 2nd, we're going to have a dialogue about governance models and feature some of those models that have worked in Vermont and Massachusetts and Oregon. So I hope that if some of you can't make it in person, you will listen online. We are recording all of these sessions and making sure that folks can hear the speakers who come and share their expertise. But please do follow along, and we're really looking forward to the conversation today, because I think it is, again, part of how we learn about what the best approach will be for the state of Delaware. This is a great opportunity, so thank you for letting me share this.
Thank you very much, Dr. Walker. It was remiss of me not to mention legislators who are here. State Representative J.J. Johnson has joined us. For those who don't know J.J., I don't know if there's anyone who's seen more of the failures or more of the room for improvement, I should say, in government and society more generally, yet has remained upright and as much a statesperson as you could possibly hope for than J.J. Johnson. So he's absolutely fantastic. I'm glad he's able to join us today. I'm not sure if I've missed anybody. I apologize that we have some individuals here who are from various legislators' offices. I know Kiki in particular, from Representative Short, most likely Representative Brian Short. Anyone else I'm missing? It goes, oh, yes? Kiki's pointing, but not at me. Okay. Actually from Representative Dave Bentz's office, and Dave is the chair of the House Health Committee. And I mention that because it goes to Dr. Walker's point about the engagement of legislators and other elected officials in the process. That ultimately is going to come down to a variety of votes, many of them perhaps tough, and the importance of messaging to constituents. It truly is a pleasure, I think, to see what's about to unfold here with Dr. Altman and Senator Moore, both of whom have gone through so many of the policy and political battles and trenches with regards to this very issue over the years. When I'd asked what kind of format they'd want to use with two individuals and one microphone over 60 minutes, they both kind of waved me off and said, "We got this. We got this." And I think that's really an extension of all they've seen and all they've done on this issue over the years. Dr. Altman is an economist who has worked on this issue at a variety of levels, and then Senator Moore as an elected official until very recently, an elected official in Massachusetts who led the charge with regard to Massachusetts health reform law in 2006, and then more recently with regard to cost containment. There's no doubt that Massachusetts is different than Delaware, and I think over the course of their discussion and then the Q&A to follow after that, let's tease out some of that. I mean, while we have the true pleasure and honor to have such informed and experienced individuals on this issue here in person in front of us, let's engage with them about how it applies to Delaware. There's no doubt there are differences. I think one perhaps silly one, but very apt, is the fact that when the Yankees come to Boston, the population of Fenway Park and surrounding bars is higher than the entire state of Delaware, for example. That matters when it comes to healthcare costs and healthcare delivery. But also just the fact that we're in a very different time now, I think, with regard to healthcare issues and federal uncertainty and all kinds of other wonderful and not so wonderful things that are happening. And I think that informs how we would implement an effort in Delaware that was implemented several years ago, not many years ago, but several years ago in Massachusetts at a time when it was more visionary than I think today. It's both visionary, but we also understand how much we have to do it. So to hear their experiences in whatever format they are going to present, because again, they got it. They got it. It truly is an honor to have people with their experience and insight here with us today. So please join me in welcoming Dr. Altman and Senator Moore.
Well, I'm Stuart Altman, and the way we're going to work this is I'm just going to lay the groundwork, and then we're going to have Mr. Health, Senator Moore, and give you the flavor for how this legislation was passed and what the issues were. And then I'm going to come back and tell you how we've been doing and what the issues that we face and I think any activity. So let me start off. First of all, listening to you, Dr. Walker, I mean, it's just like music to the ears. I mean, very much all the points you raised, very much in the minds of the legislation and in what we're all about. So I couldn't agree more. So let me just play this one out a little bit. First of all, I would like to give you a little flavor from my own life. I started off and spent most of my early career in Washington. I was a classic Fed. The truth of the matter is I didn't even know we had states. It wasn't clear to me at all that the states had any role in healthcare. People would tell me we have states, and I would say, well, maybe we should visit one and see what they look like. But when it comes to healthcare and all the important stuff, it has to be done at the federal level. And I've had a few opportunities back, more as Senator Moore, someplace around when President Roosevelt was in, as he pointed out, I was there. But the truth is, in the early 1970s, I became, for better or worse, the only federal regulator that we've ever had in terms of regulating healthcare spending. And I learned how difficult it is really to try to regulate this complex industry. And then in 1982, we fundamentally changed the way Medicare pays hospitals and doctors. And the legislature there and the president asked me to chair something called the Prospective Payment Assessment Commission. And the reason why I bring it up is because, from my point of view, and I think I had a little to do with how we designed it in Massachusetts, what we did in PROPAC was very important. For the first time, the federal government said, we want to establish, I want to say, a semi-independent agency. Independent in the sense that it won't function like another state government agency run by the governor, but we'll have a very strong relationship with the governor and the legislature, but have independence where we would have commissioners appointed by the legislatures and the president, but have them operate independently and have a staff that's somewhat separate from the state people. Not that I have anything against people who work for the federal government or the state, but there's some real important reasons why an agency like this should have some independence if you're going to really have an impact. And so learning about that and chairing that organization for 12 years, in 1990, Massachusetts hit the wall in the following sense. Our leading insurer, or our second leading insurer, Harvard Pilgrim, all of a sudden declared bankruptcy. And the state went into a real tizzy about it in terms of what were we going to do. We were already a very expensive state. Massachusetts, as many of you know, has had a long history of being involved in healthcare going back even to the 80s, where we passed a form of universal coverage. But this really hit. And so I don't know how it happened, I won't go into, but the governor and the legislature asked me to chair a task force to look at Massachusetts. And that's when I found that, you know what, states matter. They really do. And now, here we are today, where when I go to Washington, I say, you know what, with all due respect, if things are really going to get done, they're going to have to get done at the state level. I've completely changed to believe that on a whole variety of activities, states are where it's going to happen in important ways. The other thing that I want to emphasize what you said, Dr. Walker. If states are going to play a role here, they cannot just function on what the state spends. If they function only about worrying about Medicaid, and I know how important that is because it dominates your state budget, but as you pointed out, you really need to look at total spending. The relationship between government, the federal and at the state and at the private level, is so interconnected. I'm going to later on show you some slides. On average now, around the United States, private insurance is now paying 100% to 150% more for the same services that is being paid for by government. Government cannot and does not function independent of the private sector, and the private sector does not and cannot function independent of government. One of my biggest concerns about focusing is that if the private sector were to go away, much of the public sector could easily fall apart. So the idea that you're focusing, like we, on total spending, total activity, worrying about the total functioning of your health system, I couldn't agree more, and I hope you continue to do that. Because if you don't, you will run the risk of what a number of other states have done. I just worry about Medicaid. I just worry about state spending. When I was in Washington, I just said the same thing. I just worry about Medicare. Not my problem. I don't care what happens in the private sector. I don't care what happens in Medicaid. Big mistake. And it was much easier to say that in the 70s and in the 80s and maybe even into the 90s. You cannot say that today. I don't have time to go into it. I can show you how interconnected our system is. All the things you talked about. Medical homes, quality of care, availability of services are interconnected. So I'm going to stop now with my introduction, but I want to emphasize 2 points, which you will hear from Senator Moore. One is that when you do this, you need to talk about your total health system. And 2 is, as much as possible, try to put together an organization that has some independence from government, but is interconnected with government. You can't have it totally independent, because then it becomes, I wouldn't say useless, but not important. But if you have it too tied in, it becomes too political. So with that said, I'm going to turn it now over to Senator Moore to explain what the state of Massachusetts did, faced with the fact that we were the most expensive healthcare system on the planet. Not just in America, because America is much more expensive than the rest of the world. We had the only Olympic event the state ever won, which was to spend money more than anybody else. And it's an Olympic medal that we decided we really didn't want. So I'm going to turn it over to Senator Moore now to explain what hit the state and how the legislature created what became Section 224 in 2012. Senator Moore.
Thanks very much, Stuart. And by the way, it was not the Franklin Roosevelt administration, it was the Theodore Roosevelt administration. He started just to make sure that that's clear. He was just out of college at that time. I've got some suggestions for Senator Townsend, so he wouldn't end up in the position that he thinks he's in now, having voted against the resolution. I don't know, did you do a conference committee to get to the final product?
No, I know it was a simple resolution.
So that's one lesson. Always good to have the House and Senate with some tension to do that. But the way you make it work is we had my Senate Democratic colleague who was chaired at the time of the Financial Services Committee and all on the insurance legislation, which is a key part of trying to make this thing work. We had the Senate Republican leader, the House Majority Leader, my counterpart for the Joint Committee on Healthcare Financing chairs. I was the Senate chair, he was the House chair, and another Republican representative from the Healthcare Financing Committee. And when we had our meetings, we did not have a meeting unless we had lunch. We had it at noontime, we'd start our meetings. And my Senate Democratic counterpart represented the north end of Boston, the Italian section, many restaurants. So he was my expert on restaurant culinary arts. And he would be tasked to bring in lunch one day. The House actually, well, they cheated a little bit. They went to an outside member of the conference committee who owned a Chinese restaurant to bring in lunch that day. We had another one that brought in fried clams and fish and chips and stuff on a different day. So we would vary the lunches. And that set up a camaraderie among the members of the conference committee. But after you've had a full meal, you agree to a lot more things. So think about the restaurant opportunities there to help the economy. We had to take it out of our campaign because it was not state funded either. So consequently, we had to have a few fundraisers to make the conference committee go. But it's setting the right atmosphere that creates that compromise. Let me go back very quickly in a little bit of history, not as long history as Stuart provides. But when we did healthcare reform in 2006, before the federal legislation, there were a couple of key changes that we made structurally, primarily in the legislature. And that was the President of the Senate, the Speaker of the House, chose to recreate the committee structure so that we would be able to focus better on the issue of reform and dealing with quality and cost and other issues that crop up in that field. And so we, instead, at the time I chaired what was known as the Healthcare Committee. And we changed that to have a committee on healthcare financing. And under that, 4 other committees that would, all of their legislation would go through healthcare finance. And we have a public health committee, a mental health and substance abuse committee, elder affairs committee, and a small business committee, which kind of took care of a lot of the issues that focused on that. But leaving the Senate and House, the Joint Finance, Healthcare Financing Committee, to concentrate really on the bigger picture of healthcare reform. We also, when we came out of that, the healthcare connector, or some call it exchange connector, that did healthcare delivery, but really broadened the scope to ultimately 98.1% of the population was covered one way or another by health insurance. When we created the connector, that was to be reasonably independent as well. It was to, we had appointed different people, like the auditor, the attorney general, and others could, as well as the governor, could appoint members of the connector, so that it was pretty diverse. And we've gone through, Massachusetts is, I guess, thought of as being a very democratic state, but we've had governors of both parties. We also, as a legislature, which is heavily democratic, override governors of both parties. It doesn't matter whether they're a Democrat, we override those two, their vetoes. But in creating the connector, we had to come up with who would be the chair of the connector, because that would be a key role. And we ended up appointing designating the Secretary of Administration and Finance as the chair of the connector. And one of the more recent Secretaries of Administration said the idea of appointing the Secretary of Administration and Finance as the chair of that connector had to be brilliant, because the Secretary controls the state budget, and healthcare is a big piece of the budget, and so it worked well for the connector, which was making sure that everyone was insured, was fully integrated into that discussion. It wasn't quite so brilliant, however. It was more political, as sometimes things are. We tried to figure out who could we make. The Attorney General needed to be independent, needed to be able to investigate things. The auditor, similarly independent. The Treasurer already chairs most recently the Marijuana Commission, the Alcoholic Beverage Commission, the lottery, all the vices. And so the Treasurer's too busy to chair that as well. School Building Authority, Treasurer chairs. So we said, Administration and Finance, well, the President of the Senate was Italian, the Speaker was Italian, the Secretary is Italian. Let's give it to him. So he became, because he was Italian more than anything else, chair of the connector. So those kind of things happen in politics, at least in Massachusetts. But we think we're making progress on the cost containment issue. We have not solved the problem. It's not the holy grail. And so as you deal with this, you'll have variations either because of politics or because Delaware is different. You're about 1 million population. We're now at 6.8 million. So those differences, I was still not New York or some of the bigger states. But so the variation size, the demographics make a difference. How many elderly, low income, the racial and ethnic disparities, all of those things have impacts on the health system. But we think we're bending the curve in the cost growth cycle. We also think that we need to recognize that, as the old saying of Rome wasn't built in a day, neither was cost containment and dealing with healthcare reform, because there are so many moving parts as well to the healthcare system. Those are factors that even though you think you've solved a problem, a few years later that problem changes, or it's somebody else that's causing the problem that you didn't even anticipate before. So it will be something that, while the Secretary might hope that she can get this done, it's never really going to be done. It's going to continue for a number of years as long as people need health care. It's probably going to continue to be adjusted as you go on. So you won't have a total solution, I don't think, in any time because of the system itself. And I use the word system loosely because there really isn't a healthcare system. It's a lot of little systems that sometimes work together and sometimes each other. What we also had done is that before we got to the idea of setting a benchmark, We had done a lot of things in previous statutes. We actually had the health reform in 2006. And in that we criticized because we didn't solve cost growth. We did add some things in investments in public health to try to do more in creating the population need, having less need in a way, or addressing the needs of the population, as well as because we're also going to get them insured. One of the reasons that although we can't, the Taxpayers Foundation, not a little think tank, the Taxpayers Foundation in Massachusetts estimated what they thought it was going to cost, and they were pretty close to the mark, except that there was a little higher than what they had estimated because more people signed up for insurance, and there were people who needed health care that had avoided the inability to pay for it, mostly not being insured. So the people who came on to the rolls, we made it easier to get health care insurance for people who tended to be sicker or had more needs. And we anticipated a bump for a few years, and then we thought it would level off. And to some degree, I think that's improvement. We did a major cost containment legislation in 2008, when we also looked at, we need the technology, we need to help doctors, we need to help hospitals, especially the smaller ones, to get up to speed and get into the 21st century with having things like computerized physician on entry prescriptions rather than, I don't know if any of the doctors are here, but I bet you never passed penmanship very well. I wish I could sign a check like that because who knows who's sitting there. But you couldn't, oftentimes there were mistakes occurring between the physician prescribing and the pharmacist reading of what was going on. So having it done electronically and that getting the system, pharmacies were pretty much up to speed. I think we had 90% of the pharmacies, most of them were some of the major chains, who already had electronic, the ability to receive. We actually had to change a law to allow electronic signature to be effective in order to do that. But we got to the top nationally in electronic prescribing. And then we also looked at helping people to get electronic health records so that there could be more, so that because patients today, especially older patients, but patients probably of any age, see more than one physician. There's no longer the Marcus Welby taking care of everybody. There's so many specialists that enter into it, and oftentimes they did not know what the patient, who else the patient had seen and what they had prescribed. Sometimes conflicting prescriptions, things of that nature. So improving the opportunity for hospitals and physicians to have electronic health records, to be able to see what else is going on with the patient is key. We're not totally there yet, but we're making some real progress in getting a significant part of the medical population, medical profession, up to speed in this current century. The idea of establishing the benchmark, when we got to cost containment, we still hadn't done it, the costs were still going higher than we wanted them to. We looked at several themes that were, I think, consistent and that have played out in the legislature and in both the legislation and how it's been developed. We felt that we needed an independent benchmark that was determined by kind of a consensus process. So we looked at what's essentially the inflation rate or the growth rate in the state, because what if the national inflation figures don't mean anything? They're so impacted by factors in other states. So we looked at our own state growth. We actually had done a process at the State University for reporting how the state economics had improved over the previous year. And giving a group, and this sort of talk about independent, pretty independent group, who would look at that benchmark and judge what it should be and whether it should be adjusted a little bit one way or the other. We had a process already in place where the budget was what the estimate of the revenue for the next year before we get into budgeting in the legislature, or around the same time the governor submits the budget, estimated what growth can we expect, and therefore what are kind of the limits on the budget. So we have a process where the Secretary of Administration and Finance, the Chair of the Senate Ways and Means Committee, Chair of the House Ways and Means Committee, sit down and actually go through the process of agreeing on what the budget benchmark would be. And a similar process was what was used to help to create what would be the growth benchmark for healthcare as well. So we wanted to insulate the decision-making there, not only taking a fairly objective figure and then working with it. We didn't want it to be seen as the tool of any governor. We've had them on all spectrums. We'll say we have Mike Dukakis. And it seems like almost all of them have talked about, or actually one for president too, but Mike Dukakis, who was more from the left of the political spectrum. We have Romney, the other end of the political spectrum. Bill Well, we have no idea. Very easy to get the spectrum. He's all over the place. But we've had different leadership. But we didn't want the decision to be seen as a Democratic decision or a Republican decision or whatever political philosophy was in power at that time. It had to be something that would be trusted and respected by all of the stakeholders, at least almost all of them. And what would be decided and what you'd have to work toward or stay under in the process. So we created, similar to what we had done with the connector on the health reform, created a system with different actors in the state, and it ultimately turns out pretty much somewhat bipartisan, would have appointments to the Health Policy Commission. There was no Health Policy Commission until the 2012 legislation. There was a Quality and Cost Council that we created in some earlier iteration, but we're appointees of the governor. And we thought distance the group that's going to be making these decisions, just as we would have a relatively objective benchmark, but the group that can make those adjustments or determine whether you are meeting the benchmark or where you fall lower than that. That there should be that distance so that the providers, because what happens, and I'm sure we've got folks here who are involved with the Medicaid program, if the governor needs to find money, cut the reimbursement. And it's usually cut. Rarely does it get increased, but the reimbursement gets cut more because the federal government can have an impact on that as well, as to what your ratio of state to federal dollars might be. And we wanted to make sure that that people still trusted the numbers that would come out. That if the governor was a conservative, then they'd be afraid they'd be cutting. At least some areas would get cut. If the governor was more liberal, they were afraid that there'd be other decisions that made. We didn't want that to be, in the politics, it's kind of in everyday life, so it's not like you can eliminate it, but you can provide some framework in which it was going to happen. We had also, in the process of slowing the growth rate is what we did. We didn't actually expect to be able to cut, at least not in a significant way, but to slow the growth rate. That has both positive and negative impacts. On the positive side, it helps to keep the access to health care affordable, reasonably affordable. It helps to, if you have wellness and prevention programs, keeps people healthy so that we're not worried about getting sick or their family getting sick. It makes them more productive as employees, usually. They're not worried about how they feel or how other people feel in any substantial way that affects that. It's good for business. We have a healthcare system, I use that loosely, but the healthcare system is a big part of the state's economy. There are a lot of jobs involved there, and the politicians pay attention to where the jobs are too. There is also a lot of investment going on. I would assume Delaware has something of an innovation economy, as we do in Massachusetts, and folks getting into biologics and getting into all of the scientific areas where advances can be made. If you really put the clamps on too deeply, you retard the possibility of innovation, perhaps solving a problem. But you also therefore affect the investment in the state. New people wanting to come in for economic development start to get turned off if you think you're really putting the clamps on that industry as well, so you can't argue for the growth. The negative side, that it risks, in some cases, setting the benchmark too low. You put at risk particularly some of the smaller hospitals, the even some of the smaller physician practices, because you're not going to be paying them enough to handle the costs that they really have, the volume that they will have as you encourage more people to be insured. You also have the risk of, because of the population of the in the state working in healthcare or something that supports an aspect of healthcare, you run into situations where you have layoffs. So that's never good for anyone in politics to be told that some of the hospital that's the major employer in their district is going to be closing or laying off people because they recognize your constituents. And we think that what we've developed in the system that's been put together, there's one that is starting to show some progress, I think, in the process. What we did not go, and some of the folks, I think particularly some of the business folks and others, thought we should be much more strict. We should have rate setting. We had that process with the Cox administration, the Weld administration repealed it, and we haven't had it since. But the rate setting does have, and oftentimes it was arbitrary. Nobody had any real science behind the numbers. They just said, well, we're going to set it at this because we can then figure out what that's going to impact on the Medicaid budget and other aspects of the employer world. So we really felt that it needed to be more flexible, not a rigid, like a judicial hearing that you would come before. But those that don't meet the benchmark, exceed the benchmark in some way, they're told, go back to the drawing board, basically. Come back and figure out what happened, why didn't you need it, and show us what you're going to do in the future so that you can bring your costs into line with that. There is kind of an indirect threat in that the commission that Dr. Altman chairs can refer to the Attorney General any issues that they think need greater investigation. And so that's the hardest thing we've done. And of course, the potential is, if it doesn't work, the legislature could, or the governor could push for the idea of going into rate setting, since the diplomatic way, the negotiating way, didn't work. But it seems to actually be producing some results. So I think I'll stop there and go back to Dr. Altman. He because of his vast experience in healthcare, he was chosen to chair. It was also because he really didn't have much to do. And he was chosen we wanted to keep him from hitting the retirement level, costing us, the taxpayers more money out of the trust funds. But we wanted to keep him working. And we think we're going to give, in fact, the governor gave you another 5 years. So we know you'll live another 5 years. but Dr. Altman has the responsibility of overseeing this and trying to be nice to everybody while sometimes saying no at the same time through the work of the commission, which includes labor and management and all kinds of representatives that we put on it. And the other thing I will say before I let you talk about it is we didn't want to create a new bureaucracy of any size. We took what was the Health Quality and Cost Council and renamed it and changed some of its duties and added some to some way. And we also had another part of state government in the Health and Human Services Department, the Division of Health Information, Quality and Information. And we renamed that the Center of Health Information Analysis, GIA. And we said it probably would be like the plan. But we created a council that oversaw that. So it's not directly appointed by the governor as it was as if you're part of the agency. So another step, because they're the ones doing all the information gathering and research and analysis. You want that to be information that will be trusted and accepted too. It comes to the council, can ask them to do research, or they provide their annual reports to the council, and with that reasonably independent and certainly well-informed analysis, they're able to do the job, I think, pretty well.
one of the things that Senator Moore slid over and didn't really explain, we don't get paid.
It's an honor.
It's an honor, it's a privilege, and it's a lot of work. But it is an honor for me. And so a couple of things, just as Senator Moore pointed out, we are in, and now if you could put up the slides. I had slides. To explain what we've been doing. Sorry. So let me, so I had as I said, in my earlier part of life, I really was a regulator. In 1971, where the federal government actually regulated. And I want to make it very clear, I was fantastic. I have three characteristics. Okay, good. There are three aspects you want to, if you want to be an effective regulator in healthcare. Three aspects. You should know absolutely nothing about the industry. Because once you start worrying about the industry, I mean, he's a politician, he worries about jobs, worries stuff like that. You can't worry about any of that stuff because you'll never do anything. I was 31 years old. You know, I'm a PhD economist. I didn't know anything about healthcare. I was perfectly situated to be the chief regulator. You know, second, you really need to be young and healthy. Because once you start needing health care, you know, you get into trouble and stuff like that. And third, you need to be very arrogant and feel very confident. Now, I'm an economist, second to surgeons. We're the most arrogant people you ever met. So I was fantastic. Fortunately, by the time I figured out what I was doing, the federal government ended the regulatory structure, so I never had to pay the price. And then so now I'm not a regulator. I made it very clear. I don't qualify on any of those characteristics anymore. I'm no longer young. Truth of the matter is I'm falling apart. I care a lot more about the health system. I tell them, when you get me under the sheets, I want you smiling and happy, you know. And two, you know, I now know a fair amount about our healthcare system, and as a result, I'm a little less arrogant. So we are not, and I tell people, we are not a regulatory body. So the question is, what are we? So people keep asking me, what is the Health Policy Committee? What kind of madness did these legislatures create? And I tell the healthcare system, just think of us, think of me like your mother. My job is to go around and tell people what they should do. Eat your vegetables, behave yourself, do a good job, keep healthcare spending lower. So that's my job, that's our job, is to try to understand the forces that are working, try to push them in ways that make our healthcare system more efficient, higher quality, and lower cost. As Senator Moore pointed out, based on the structure that they put together, we have this benchmark, which is equivalent to what is considered a long-term state income growth rate of about 3.6%. We have many functions, and had I read all the legislation when I took this job, it wasn't completely clear I would have taken it, because they gave us a lot, not only to worry about costs, we are to do just what you said, Dr. Walker, we are responsible for concern about quality and access. They gave us $160 million taken from the high spending providers to sort of focus on improving quality and access. We created, and I won't go through all of the things we have to do. I know David Seltz was here talking about that. So we monitor and create health, as pointed out, medical homes and accountable care organizations and so on. But one of our very important functions, and you can't lose sight of it, is that we need to monitor this complicated system. And most importantly, we have to evaluate all new healthcare mergers and acquisitions to determine the impact that merger will have on cost, quality, and access. And one of the things you learn very quickly in this job, if you don't already know it, Everyone always wants to do things that are going to be good and cause no problems. And the reality of it is that if you look over time, most mergers and acquisitions, while they may improve quality a little bit, unclear, they may improve access, unclear, they usually raise costs. And so we have become quite the arbiter in terms of going in, and little did I know, the day after practically we got going, our largest healthcare system, some would say the largest and most powerful in the world, Partners Healthcare, decided it wasn't big enough and it wanted to expand even further, and we go, what? And three-quarters of the state said, what? And anyway, we went through a long process. It's now made all the textbooks, and we basically said this is going to really add costs. Ultimately, we had to make a recommendation. We can't stop it, but we made a recommendation to the Attorney General. The Attorney General ultimately let it go forward, but with a lot of conditions, and ultimately the state court came in and said, no. We don't want to give all these conditions. You just can't do it. And it was stopped. So in addition to, and now we're facing another whole group of mergers and acquisitions from our big systems, and we're looking at that. Second, as Senator Moore pointed out, we review all increases that exceed the benchmark to find out why. Why do you need to spend more? We were already giving you growth rates of 3.6. And if you're up to 5, 6, 7, 8%, what is the reason? And more importantly, can you develop a plan to get down to the benchmark? And if there is goodwill, and there has been goodwill to try to do that, that's fine. But if you run into a provider or a payer that really said, I'm just going to do what I'm doing, we have the ability to find them. And most importantly, we have the ability to point our finger at them. And our newspapers in town, particularly the Boston Globe, is very anxious to put on the front page of the newspaper what will happen. So, as was pointed out, we have 11 commissioners appointed by the governor and the attorney general and the auditor, and the governor, first the Democratic governor, now a Republican governor, asked me to chair it. Now, so as I pointed out, we can penalize if groups exceed the benchmark. So let's just go into what's happened, just so you get a flavor for what's going on. So we started back in 2012-13, and so first of all, based on results from CHIA, our sister organization, you notice that now, important to understand, this is per capita growth, and it's total. Very important. This is all spending, including out-of-pocket, with insurance companies, with the federal government, with the state government. Our per capita growth was initially 2.3, and after adjustment, 2.4, significantly under the 3.6. Then we popped up in 2013-14 to exceed the benchmark, but there were some very good reasons for it. This was the era when the federal government legislation was coming online, and particularly our Medicaid program, Mass Health as it's called, brought in a lot of new people, and as Senator Moore pointed out, many of these people were sick and really needed extensive care. So the initial estimates were 4.8, the final was 4.2, slightly over 3.6. We also exceeded the benchmark in 2014-15, and I'm happy to report we just got our report for 2015-16, and again, we're under the benchmark. And if you add up all 4 years, we are at 3.5555. We are under the benchmark. At which point I'm resigning because I don't want to go. I tell everyone, they point to me, I don't know why me, or our group, and they go, well, did you succeed? I want to, no. I don't want to take credit for succeeding because I don't want to get blamed if we don't. And one of the things that Senator Moore said is very important. Overwhelmingly, all the forces in Massachusetts agree to this. Thank you so much for the way you did it. Yeah, everyone's complaining and bitching and moaning here a little bit, but for the most part, the providers, the hospitals, the doctors, the insurance companies, the employers, our community groups, our religious groups, are all into this. and they all wanted to work. And that's the most important thing. This was not jammed down the throat of the system. So thank you so much for what you've done. Now, how have we done taking this? It's very important to look at not only Massachusetts or Delaware in and of itself. It needs to look at it in the context of what's going on nationally. So here are the statistics. Look at the kind of the orangey line. That's Massachusetts growth. You'll notice in the period from 2000 to 2000, roughly 7-8, we were significantly over the growth in spending for the rest of the country, which is in blue. But beginning in 2009 or so, and particularly since 2010, we have consistently been below the national average. And that is unique to the system. More importantly, sometimes, if you look, remember, this is total. And what's critical, and don't lose sight of it, is what's going on in the private sector. And if you look at what happened in the private sector, our commercial insurance rates, again, in that period from 2006 to 2010-11, private insurance rates were growing faster than the national. But beginning in 2011 and 12 and 13 and 14, 15, we are significantly under the national. Now, when you then look at us, average annual spending growth per capita in the state, that red bar at the end, that's us. We have never been so low relative to the country. We are the 4th lowest growth rate in this period, 2009 to 2014. So we are at 2.32, where the national is 3.14, and I'm sorry, there's Delaware at 4.06. So I can see why you want to take a hard look at this. And again, when you look, and Dr. Walker pointed it out, you know, at one point we were sitting there as the #1 state in 2009, and now, you know, well, Alaska. Well, Alaska's not like the rest of the country. You know? Some would say the same about Massachusetts, but for different reasons. So we feel good about what we're doing. I think most importantly, and I'm just going to stop here, trying to understand the forces. And one of the things that I really liked with your presentation about is you pointed out that you really want to understand what the forces are, and that's very important. And you particularly want to focus on those aspects where we're not getting our money's worth, and even worse, where in fact spending more money actually deteriorates good health. And as a physician, I'm sure you know that. We spend a lot of time, and we issue several reports a year, which I'm sure you've seen, or if you haven't, we're more than willing to give you, understanding what is our cost drivers. On the 2nd and 3rd of October, we're going to have 2 days of hearings, which we are required to do every year. Very important. And interestingly enough, we require the major CEOs of our health plans and our health delivery system under oath to make presentations and to explain what they're doing. You know, there are forces that are growing, you know, but we're seeing hospital care costs come down. Long-term care growth, which you're now more involved in, has been actually growing faster. And we're a little concerned about that, why it's growing so fast. Professional services, drugs are growing a little faster. So I'm just going to finish. Why is it working? Again, we are not a regulatory body. We don't have, and I think the most important thing is what I said before. Most of the forces in the state bought into this process. Nobody wants to be singled out as an outlier raising growth. We have strong political support, and we have a lot of activities going on within the delivery system and within our payers to make this system work. Our Blue Cross plan is one of the leaders, if not the leaders, on the private insurance side to change the way it pays doctors and hospitals. Our big health systems partners, Beth Israel, Leahy, and so on, are really trying to change the way they practice medicine. our big physician groups are very committed to moving towards medical homes. So we are not imposing this on them. We are working with them, and that is critical to make this work. And if recently, based on the legislature, we now moved beyond the 3.6. And the legislation that was passed says to us, you as the Health Policy Commission can change the benchmark. Now, we would like to see that benchmark lowered. This is what the legislation said, to 3.1. But if you don't think you could do it, you could stay at 3.6 and maybe even you can go above. What was interesting, every one of the major groups in the state, other than the physicians, said we want to go to 3.1, including the hospitals. And so we recommended 3.1. And so beginning next year, January 1, we're at a benchmark of 3.1, agreed to by all the major groups. Some, like the business community, wanted us to go below that. But as Senator Moore pointed out, we are in this, this is an important industry. It affects people's health care. It's a major employer. It's a major innovator. And trying to titrate that, to grow but not overgrow, and to grow, most importantly, in line with our income is very important. So with that, I'll stop. I hope we're right on time. Actually, we're pretty good. All right, and then we're Senator Moore and I, and I'm sure Governor Dr. Walker are more than willing to answer questions. Thank you very much.
Thank you very much, Dr. Altman, especially for catching us up on time. It was brought to my attention, people didn't raise their hands, which is okay, we'll talk about that later on, but sent me text messages that we do have a few additional elected officials represented here today. Senator Stephanie Hanson's office represented by Jennifer Parrish, Brian Fahey with Senator Del Colo, David Deputy, Chief of Staff to the Senate Republicans, and then the indomitable Annie Gould, my own office. For all of those of you who deal with me, dealing with Annie is a lot more pleasant, so feel free to talk directly to her about anything and she'll translate what I meant to say. Also, taking up Senator Moore on his offer to use food to try to forge political compromise, I would ask David Deputy to please figure out whatever Senator Lavelle's favorite dish is that helps alleviate his heartburn. We'll start ordering that to try to forge some consensus here in Delaware. As before, we have one microphone, we have three fantastic individuals, and hopefully we have a bunch of questions in the next half hour or so. And that's for the sake of online videotaping. It's a small room, but if you can ask your question, make sure you're heard, and then direct it to whichever individual you'd like. They'll answer the question and try to maybe repeat it real quick so it's picked up on the Facebook Live and the general videotaping. And let's just see if we can all work together to make this go as smoothly as possible. Is anyone, it's a room full of dignitaries, a lot of people are experienced here. Any questions? And we also have a roving mic apparently, so that'll be fantastic too. But it's a small room, so let's try to get as many questions as we can and not wait for lots of mic movement. Any questions out of the gate?
Thank you, Senator. Thank you to our guests and speakers. Wayne Smith, I represent hospitals in the state of Delaware. When you talk about this covering all providers, does that mean that long-term care, pharmacies, outpatient, they have to report also, they're subject to the same scrutiny?
Yes, as I said, it's all providers. And the one area which is now under serious review is the one group that have not been financially participating but very involved is our drug industry. The legal drug industry. Not confused. So they are very much under review. And we've had representatives of the biotech industry, the pharmaceutical industry, testify in our commission. And as you might expect, we're very concerned about high cost of prescription drugs and its impact. So yes, all segments of the healthcare are included.
Jonathan Kirch with the American Heart Association. I'm going to ask a question that's pretty broad. and sort of lead up into it. I was at a talk that was given by Dr. David Cutler, who might be someone who's familiar to the two
He's
of you.
on our commission, yes, good friend.
And one of the things that stuck with me from that was he was talking about the projected increases in healthcare spending, and he said, anything that can't happen won't happen. And he was talking about how, I mean, we've all seen these projections of the pie being eaten up by healthcare spending. And he said, it's not going to happen. Something else is going to force things to happen. So the tough question I'm going to ask that's kind of broad is, did this work? So Massachusetts is now one of the healthiest states in America, according to your health rankings, so congratulations on that. You're still very expensive. So say more to convince me that it worked, or because I'm left wondering if, all things being equal, you may have still wound up in the place you are now anyway.
Well, I mean, you know, one could never know for sure where we would have been. I'm reasonably comfortable with saying that we would not have entered and reached the level we're at were it not for this legislation. Now, I don't, and as a matter of fact, I think David Cutler would, no, I know David Cutler would agree. I think you may have little misinterpreted what he said. He did not say whatever's going to happen is going to happen regardless of what you do. He never would have said that. Now, but I think your broader point is a good one, which is, you know, I think you need to be careful. And I think the comments of the Secretary and the comments that I made and that Senator Moore made, I think we are being careful in trying to lower and bend the curve, and I'm going to let Senator Moore comment about this, without, you know, there are some people I think are irresponsible with making up numbers. Oh, why don't we lower it to 3% below GDP? Why don't we, you know, I mean, why don't we become England? I hate to tell you, we're not England. And we're not Canada. We are what we are. So your general comment I agree with, and that is we need to be careful, but there is no question in my mind that we would not be the fourth lowest growth over the last 4 years were it not for this legislation.
A couple of observations on that. One is and Dr. Altman mentioned how the legislation envisioned for 2017 through 2022, the cross-growth curve would be dropped by 0.5%. And that debate was advocated very strenuously by the House, and the House Chair of Healthcare Finance, who just became the president of the Massachusetts Hospital Association. So now he's going to have to live with what he advocated for so well. But it's interesting that so many of the providers have agreed to try to meet that. In 2022, it goes back to whatever the commission thinks is appropriate at that time. The hope is it does have some impact. But there are two factors that are difficult to control for a state. And one is the drug costs. And we do have some manufacturers in the state, certainly, but they're really national or international manufacturers. We tried doing that, and still, some of it's still on the books. We did academic detailing, which is that we sent out people who had an objective view of what the costs ought to be and how marketing should be done to visit with doctors who are high prescribers of brand names in particular. We also had a requirement, and I don't think it's still honored, but a requirement that every gift or payment or whatever above $50 had to be reported to the Department of Public Health, so that and it was a public report online. That lasted a couple of years, and then it was relieved of the reporting. And it wasn't the pharmaceutical companies that directly pushed it; it was the Restaurant Association, because they were entertaining the doctors and getting paid by the pharmaceutical companies. They were the ones that lobbied heavily to change that. So you have to watch where the bump is going to be pushed, and it's not always the ones that you expect. We also did, I thought it was kind of innovative, we took the Big Pharma's code of ethics and made it a statute and with penalties. They came to the hearing and opposed it. So they're tough. The other thing that affects costs and difficulty to control costs is scope of practice. Every part of the profession jealously guards their piece of the pie and won't let anybody who has different qualifications and perhaps a lower education requirement or whatever do what can be simple, like giving an injection or something. They won't let them do it. And as long as that stays, I think we probably have some people here from the Delaware Medical Association. My common line to the Massachusetts Medical Society was they haven't had a new idea since Oliver Wendell Holmes Sr., the doctor, not the judge, told people they should wash their hands before moving from one patient to another. They constantly object to any change. Now, they may have sometimes have valid reasons, but I never thought they're so valid that they needed to stand the test of scrutiny.
First of all, let me totally agree with that. I understand that our Senate is now proposing expanding the scope of practice for advanced nurse practitioners and for other well-trained people. The other area I want to bring up, which we have not talked about, other than regulation, you got to make markets work. I'm enough of an economist to believe that. In order to make markets work, you got to make markets work. And one of the areas that we're seeing is that a number of our insurance companies are going to some form of tiered or limited networks, provided they're adequate. In order to make those work, you cannot allow certain providers to charge it very much in excess of the rates, particularly for those aspects of healthcare where people have no choice, like emergency department, or people where the surgeon is in a network and a hospital's in a network, and the anesthesiologist and the radiologist, all of a sudden you get a bill as a consumer 10 times, 5 times what your insurance will pay for. So you need to make you got a choice. You got 3 choices. If you don't let markets or regulation work, then you just, it's Katie bar the door. And, I'm a believer that based on our trend lines, we were projected to consume 100% of GDP in healthcare. As my friend Uwe Reinhardt said, ultimately we're going to wind up where just one bed is next to the other, and that's it. That's our healthcare system. And I started at 7% of GDP, and I would have, bet my first bond that we'd never hit 10%. Now we're approaching 20%. The other thing that Representative Townsend brought up that I think was very important, some people said, well, you should adjust for cost of living or income. Now, first of all, when you compare your growth rate when you compare your growth in spending to your growth in your income, you're already adjusting for your cost of living because both of them are adjusted for inflation. So you don't need to do that. Second, it is true that Massachusetts is a high-income state. So if you looked at our spending relative to our income, we're like not close to the middle. So some of our people would say, well, don't worry. Understand, and I'm sure the same thing is true in Delaware, not everyone in our state is in the top 1% of income. We have a big segment of our population who are, just, barely making it. And to tell them, oh, we don't have to worry about healthcare costs, which are approaching 20% of our GDP because it's only, because we got mega billionaires running around. They don't buy it. And so we have a responsibility. So we will not and have not adjusted for our income. Not that we're not mindful of it, but we will not adjust totally for that. Other questions?
I have a question from Facebook Live. John would like to know, he's looked at the report, how is your patient and consumer engagement?
I will tell you this, our consumer involvement is wonderful. We have a interreligious council that monitors all. They come to all of our presentations. They issue reports. They push us, and I'm so glad they do. They are very, very conscious. And, you know, I mean, here's the tricky part. We want to be very conscious of people with serious illnesses. You know, and as I said, I'm falling apart. I care a lot about you. My heart beats every other day, you know. I want to keep it. So we're very conscious of illness, but these consumer groups are also conscious of the fact that healthcare costs and spending is the leading cause of bankruptcy. So yes, we are very much committed to consumers.
We also, in that statute, created a requirement that every hospital has to have a patient and family advisory council. They all do. And they vary a little bit by how active they are. If the administration of the hospital is taking it seriously, and most of them do, those councils do meet and they did get listened to. They also advise on how to dispense community benefits. All hospitals is almost all are nonprofit. They have to set aside a certain point of their revenue to do something that will help the community, and the focus has been on that will help deal with health cost issues or public health issues to really look at prevention and wellness. We put money into prevention and wellness. We put money into helping the at-risk hospitals. We put money into workforce development. And one of the big things is the physicians, you know, the burden that they have to get out when they get out of school to pay for their education is such that they're pushed toward specialties that will reimburse better than primary care. And yet, all levels of primary care, we struggle to get people in. So what we're focusing on is that scholarship or tuition payback assistance needs to be targeted, at least for a period of time, the person receiving it agrees to do primary care in some of the underserved populations.
Good morning. Thank you for your wonderful presentations. My name is Irene Waldron, and I run the Delaware Healthcare Facilities Association, which is the chapter of the American Healthcare Association. So I represent long-term care facilities, including skilled as well as assisted living. We have seen a huge shift in the continuum of care over the last, 5 years since you started this commission in Massachusetts. And my question is, how has the commission been able to flexibly handle the shifts that we have seen with the expansion of home and community-based services and the growth of home and community-based services and group homes, et cetera, because all those affect the quality of care that we deliver as well as the cost of care that we deliver. And I'm sure you've had to be very nimble in order to keep up with all of it, because I've been in the field a long time and I'm having a difficult time myself. Thank you.
Thank you. And yes, you're absolutely right. So let's understand the way this legislation was put together and what we do. We do not control, or do we, the structure of the delivery system and how it's changing. What we do is we try to encourage it to move in certain directions. And there's a lot of reasons why the post-acute / long-term care community is changing, having to do with the practice of medicine and to the changing reimbursement system. And that is somewhat at the federal level. I mean, moving to accountable care organizations, moving to bundled payments, moving to more capitated rates, fundamentally changes the nature of first the payment system, but more importantly, the delivery system. So now there's much more discussion going on between our acute care facilities and our long-term care facilities. There's nothing worse than a fee-for-service system that just leads to everyone for themselves. And so the idea that we're building more of home care and community care partly is being generated by the delivery system and the change in the practice of medicine and the technology. We can do things at home that we would only dream of 10, 15, 20 years ago. So a big part of it, you talk about telemedicine, you talk about the kind of understanding of patients and how they're feeling in the home where, thanks to technology. But part of it is being driven by the changing reimbursement system. And that we are encouraging. So again, we're encouraging, but we're not directing. And one of the things that I've learned in my more than 5 decades in this industry is no matter how smart you think you are, you're not that smart. So there's value in allowing a variety of forces to play out and try to pick the ones that seem to be working best and encourage them to be continuous. So that's what we're doing.
Thank you. Representative J.J. Johnson, first of all, I'd like to compliment all the presenters, Dr. Walker, and the host, Brian Townsend, Senator Brian Townsend. And you did well, Senator, considering you voted against the resolution. Actually, I had a similar experience. I'm also on the Joint Finance Committee because that's why I'm concerned about health care costs, because the last 2 budgets we had were, I wasn't very proud of. And considering that, a couple of years ago, the Joint Finance Committee voted on putting together a task force, and they wanted to put members on the task force. And somebody suggested that I would go on the task force. I said, no way. I said, my experience at task force really do not accomplish a lot. And so they agreed not to put me on the task force, and they put the 2 co-chairs on the task force. Something happened, and one of the co-chairs couldn't be present at the task force meeting, and guess who was put on the task force? Yours truly. And the only thing we could agree to on that task force is agree to disagree. But one of the things we mentioned in that task force, and this was a year or 2 ago, was a concern about the lack of competition with healthcare providers. And Delaware being a small state, we only have 1 major hospital in the state. And was a lot of proposals presented as far as having a regulatory commission, something similar to what they have in our adjoining state, Maryland. And a lot of the members thought that would be the best way to go to be able to address the fact that we have such a limited amount of healthcare providers. And I understand you said earlier that the commission itself is not a regulatory commission, but do you have any types of regulatory legislation in the state to address costs?
So, as I said, we're not regulatory, and the answer is yes, we have a number of regulations that are important. We have a strong certificate of need system, which means that any facility that wants to be built or expanded needs to be reviewed. We have an attorney general who's very active. She is very conscious of the need to maintain as much care in the community, and we're very concerned about our community hospital system. We're a very highly concentrated healthcare system, probably one of the most concentrated in the country. The amount of care that's provided by our academic medical centers exceeds almost every other state. And we love our academic medical centers, and they do wonderful things, but they're also very expensive. And if we don't maintain a community system, we're in deep trouble. So we do have regulatory capacities to do that. What we don't have is rate setting. And I will tell you, on odd Tuesdays, if I get frustrated, I say, well, maybe, I spent 6 years as an advisor in Maryland, so I know the Maryland system pretty well. And they do wonderful things, so I'm not idling. So they have certain advantages in terms of regulation, but their regulation is primarily for inpatient care and some outpatient care. They're trying to move towards global budgets. The thing that we do, and I'm urging you to do as well, is don't just focus on one side part of the system. It will pop up all over the place. You're much better off looking at your total system, whether it's long-term care, whether it's outpatient care, whether it's telemedicine, whether it's drugs. but to do it in a way that doesn't tie you down. And the more you look at, the bigger the system, the more difficult it is to regulate. Because, as I said, bubbles come all over the place. There are people today, you know, if the numbers I had showed you were different, and we had blown right through the benchmark, and we could, I think there would be a lot more pressure for us to regulate. But right now, our system is working. I love your question, though. Whether it would have worked that way or not, I don't know. You know, so right now, I would say we are a partial regulated system, but not a rate-setting system.
Thank you.
Good morning. My name is Valencia John. I'm a doctoral fellow at Nemours Office of Health Equity and Inclusion. And I'd like to thank everyone for their presentation. My question is directed to Dr. Walker. So I know in your talk you mentioned evidence-based research and population health. So I wanted to know if you were collaborating with others outside of your office to work, you know, on more of that.
Thank you for the question. We absolutely are. I mean, I probably could talk for an hour about what we're doing around specific populations and health disparities and equity. Certainly, we have a plan, strategic plan around making an impact in health disparities, but it has to be integrated into the outcomes we measure and pay for. And I think that's the next level, right? I mean, as an academic, recovered academic, and someone who definitely has done myself the health disparities work, some of the challenges in actually having levers to make impact are that it is hard to, one, provide that feedback loop to the providers who are actually monitoring patient by patient, right? If you don't have that public health perspective, it's hard to know. You're just dealing with the patient in front of you. So we're actively seeking opportunities to work together, particularly around the healthy communities work that's led across, you know, stakeholder groups. But I think those are important ways that we can partner, and I'd be happy to talk more about that. Thank you for the question.
Thank you. I'm Stephen Costantino. I'm the Director of Healthcare Reform Secretary's Office. I know a few of these people because of my past history, being a legislator in Rhode Island, Secretary in Rhode Island, Commissioner in Vermont. But I know that behind any compromise, and I know you've kind of run over it, that it took a lot of work in getting this bill passed and made into law and actually implemented. Just to, and I know this question can probably go on for just really trying to get the core out of your ability, both of you, your ability to get payers, hospitals, physicians, consumers, to really rally behind a piece of legislation in which there were, I would suspect, some fears, a lot of fears. What was the kind of the thread that went through all of that to have some kind of rallying point on a piece of legislation that, albeit had to have some compromise issues in it? I was just, how did you get to that point? And I know, again, I know it's a pretty broad question, but really want to try to get to the really core in the sense of how you did it.
I think largely is we listened to a lot of people and a lot of different groups and sometimes competing groups in the process. A great example, which was part of our, not this bill, but the bill before that we did on cost containment, was on looking at end-of-life care. At the time, the national debate was about death panels. We were able to get an expert panel put together of folks, including all the different religions and ethicists and others, who came up with a very good recommendation. Even on when we did health reform, we listened to one of the religious groups that doesn't Christian Scientists that don't really believe in the impact of direct medicine. Prayer takes precedence over. And we provided an exemption for them. However, if a person who was a Christian Scientist and claimed that exemption, then sought treatment in the traditional way, there would be they'd end up paying the penalty for non-insurance that everybody else pays if they're not insured. But we listened to everybody that had an issue and tried to address it as we crafted the policy. So I think it's really, and I think the Secretary Walker's, it seems like you're doing that from your presentation, that you're making sure that stakeholders in functions like this have an opportunity, and a lot of these people will listen and they won't necessarily say anything now, but I think as the discussions go on, they'll formulate suggestions or positions or whatever that then need to be integrated into the final answer. And everybody was I think Dr. Allman made a point that why people come to agreement. Nobody wants to be against trying to keep costs from going up. It's not a good political position or public position to be in, that you're up for spending more money just for the heck of it, or just to get more wealthy in your own field at the expense of everybody else. So I think it's kind of the shaming of somebody who violates the benchmark. That's a big factor. You mentioned it with the Globe. The Globe is on top of any sort of major newspaper or some other of the iTunes and stuff like that, television. They get on it. That will oftentimes bring people around to trying to avoid it. Really, I think, was listening and trying to accommodate without weakening the program, without oftentimes strengthening the program. That was a big part of that, including, for instance, in the Senate, we had, at the time of healthcare reform, we had 4 Republicans, 36 Democrats, and the ratio is still pretty much in that way. But we include the Republican leadership, and actually all the Republicans, in the discussions and accept some of their. We don't just dismiss it just because it's coming from that party. I don't know, they have some pretty good ideas, so we incorporate that into it too. We tried not to make it at all partisan. When healthcare reform passed and when the cost containment passed, the Senate was unanimous. In the House, there were just a couple of dissenters. We tend to be very conservative members, but we made an effort to reach out to people that had other views and try to figure out is there a way to come to yes on that. And mostly it worked. Somebody calling to complain?
Yes, ma'am.
Thank you. Thank you for your presentation. It's very interesting to hear how Massachusetts has been working in this realm. My name is Lolita Lopez. I'm president and CEO of Westside Family Healthcare, a federally qualified health center. One of the questions I have is, how did Massachusetts address the social determinants of health in trying to keep costs down? As we know, community health centers deal with these issues every day, and as we move more toward population health and looking at social determinants, the fact is the cost of providing primary and preventive care actually goes up. And so there feels like there's a little bit of tension there in terms of how we can do both things simultaneously. I know that Massachusetts has a very robust, federally qualified health care system, and so my second question is, how was that system involved, and were they at the table as you proceeded with this process?
So let me answer the first part first, which is they're very much at the table. Our federally qualified centers are, as you said, they're large, they're politically powerful, and they're really doing a wonderful job. Now, I'm glad you brought up social determinants. So, and again, I want to go back to my answer before. We, the commission, the legislature, again, does not control the system. Again, we try to mold the system. And we have become, like most other parts of the country, very much positively feeling about social determinants. I think it's one of the big breakthroughs that when I say we, those of us who study our health, we learn that good health is not only totally determined by the healthcare system, but that the best estimates are that healthcare services only provide about 20% of what makes for good health. And a much larger percentage is based on a whole set of factors which we broadly define as social determinants. And one of the things that separates the United States from other countries is the fact that other countries spend much higher percentage of their income on what we call social determinants than we do. So we're very conscious of the need to reinvest. And you brought up this tension. Well, the tension exists, no question about it. But if you change the payment system in a way that rewards good health as opposed to just doing, and you can get at things that really don't add to value and redirect those funds. So the whole essence of accountable care organizations is to pull spending out of our most expensive and ultimately least productive at times activities and redirect them towards the beginning, towards primary care and social determinants. If you do that, it's a win-win. You can lower costs, improve health, and actually expand the social determinants. The idea that we're just going to add more money into the system and then pay for social determinants ain't going to happen. Given the nature of how much we're already spending, we need to redirect funding from those aspects of our health delivery system that are, as you pointed out, wasteful and if not harmful, towards those aspects which really do add to good health. And I would put social determinants high on the list. And that's what we are. So when we do our, last year, we had a whole section of our cost containment on social determinants. And we have a wonderful legislator, academic, who has now gone back to graduate school. And she laid out about social determinants and we said, well, all right, where should we be investing? And things like housing for people who are homeless often is a much more important investment than more health care, strictly. So, we're, again, trying to focus. We don't control the budgets. We can only put a searchlight or a flashlight on where we ought to be going.
My name's Greg Wilson. I'm a consultant in community outreach. I have a question on the communication strategy that you implemented to sustain public support for your efforts. You talked about bringing different stakeholders together. The interests or the challenges that you face on the Cape are different that you face in the Berkshires, North Shore versus South Shore, different delivery systems. Did you use primarily print, broadcast media, and social media? And who was the person responsible for making sure that was effective in your outreach?
So I know you had David Selfs here, who is our executive director. David's done a wonderful job in the commission. So we have a very active social network. We make good use of social media. We have a very extensive website. We issue reports. We go around the state. David has a council that reports to him of all the major stakeholders, and they meet monthly or bi-monthly to discuss the big issues. Again, the media has been very supportive of what we're doing, not only the newspaper, our public radio stations. It's not that we're part of the process, but we couldn't do it alone. You really do need buy-in from a lot of components. And again, I want to thank Senator Moore and the legislators who put this together, because I tell you, if you had done it differently and you had jammed this thing through, my life would be miserable. As it is, it's hard, but it would have been miserable.
We've come to the end of the scheduled program, and now we'll have closing comments. I invite each of the three speakers to give final thoughts based on what we've discussed and where they feel we need to move ahead moving forward. And as Dr. Altman started with Senator Moore and then Dr. Walker. Yes.
Well, first of all, I'm so pleased that you did your first presentation, because I think the way you laid it out is right on. the issues that you need to address. You can't just address costs. You need to address the whole panoply of the different things you need to do. Costs are important, but they're in the context of what you're doing. Second, the idea that you're focusing on total spending and total health. And good health, not just necessarily insurance, not necessarily the delivery system. Very important. Again, I would emphasize, I think it's important. I like to believe that the way the Health Policy Commission was set up and how Senator Moore and his colleagues put it together is the right way to do it. I call it semi-independent, but very connected. We are very conscious of our, in a lot of ways, what our governor thinks, what our legislators think, but I try to, be independent, and so do my fellow commissioners. I mean, I don't consciously ignore what our governor or our Senate president or I do, but I don't feel that I have to listen to them all the time. It's very important that this activity not be too political in a day-to-day sense, and yet be political enough that it's not going off in a crazy way. So I like the way you're thinking. Most importantly, we could use some friends. You know, you may be a little state, but you know your history is on your side, and you're a wonderful state. So we welcome you to come join us.
Dr. Altman is lobbying to create a National Association of Health Policy Commissioners. He's currently the president of that association, but there's only one member. So if you join, then you could be president of the association. He's willing to give that up. I think the one thing I would I think you're in the right direction. I think the scope that you did lay out actually was very helpful. To listen to your director of health reform, because he's got the background and the knowledge to do that. He told me to say that. And but also understand that the benchmark is only possible, or achieving the benchmark, if you do some other things in the healthcare system. Dealing with the disparities, for one. Dealing with the scope of practice is I think, an important one. It's very difficult. Looking at, I don't know if Delaware gets into medical loss ratio. When we look at when the insurers, how much of the money that they take in for premium actually goes to healthcare, and we want them around 90%, so that they can't be spending it on nice buildings and other things that they're going to. They really need to show that they're spending on it. I think looking, the insurance industry is a part of this whole process, and they need to be very much involved in perhaps insurance reform. So the payment reform issue, I think you're moving in the right direction. That we're looking at patient-centered medical homes and accountable care organizations and things of that nature to look at how we can not necessarily spend less, but what we're spending, spend it more efficiently, and that it really has an impact on the health system. And certainly prevention and wellness. Healthcare is very cheap if you don't get sick. So you can keep people from getting sick, and that's particularly important with the elderly. The elderly, one, they take more drugs than a drug addict in many cases, and that they don't stay active many times. They need to exercise. They need to do things like that to try to reduce falling. Falls are the biggest issue for elderly people, because it's the beginning of the end. They break something, hit their head, or whatever it's going. And I think the other one, which is very difficult to do because they are so powerful nationally as well as in the States, is the drug industry, the drug costs, because they're increasingly solutions. Although anybody who listens to the drug commercials wonders, why am I taking that? When you listen to that little litany in the end to cover themselves legally, all the side effects and everything else that goes. So hopefully the drug companies will work on getting rid of the side effects and making them really effective for what it's supposed to do. But the cost of the biologics, and specialized drugs that are just a small part of the population, which I think is important, but there's also got to be some social conscience on the part of the industry too. We're looking at that. Some do, but unfortunately the big ones don't. So those are kind of things that it's not just the benchmark, it's all the things that drive costs up. So looking at those and trying to do collectively, doing as much as you can. Politically, it's not an easy thing to do.
certainly learned a ton today, and I want to first say a special thank you to Senator Townsend for being willing to be a collaborator and lead this charge. And maybe the approach of HJR 7 wasn't exactly well suited, but we do need to work on the stakeholder engagement process, because that is obviously critical to what the solution and the approach will be. I just want to say a special thank you to our two guest speakers, Dr. Altman, Senator Moore. I have heard so much about your path from things that have been written and then colleagues that have come down to our state to help guide us. Your leadership and progress and call to action for us is truly inspiring and will carry us forward. I also want to say thank you to Representative Johnson for being here and for also raising questions and pushing us on cost containment, whether it's in Medicaid, state employees, or beyond, because we have critical needs that we need to do as a department, as a state, and your leadership is critical. I so appreciate all of you for being here and the other staff members from legislative offices who are here and part of this dialogue and asking questions along the way, because it's so critical. And I have to say a special thank you to the staff who pulled this together. It takes a village to put something on live Facebook and make a room look beautiful and to just pull all the logistics together. So I want to say thank you, and to all of you who have had ongoing side conversations with me and given me advice. I just, since you gave me the mic, sorry. I just want to say, you know, this is part of our stakeholder engagement process. We do want comments, we do want feedback, we do want more convenings like this. And if you think there's a place that we should sit down and talk, let's organize that. There are so many of you who have laid the foundation for us to be here today, and we collectively, I believe it, I feel there's momentum that we really want a healthier Delaware. We want a healthier community. We want to focus on lower rates of diabetes and substance abuse and really tackle on the hard things around violence and opioid use in our state. And this is a mechanism for us to come together and figure out how to organize ourselves to achieve those goals. So I just really want to say thank you for the partnership and for the opportunity to put these forums together and to be here and to continue to engage in dialogue. So I'll turn the microphone back over to you. Thank you, Senator.
Thank you all very much. To echo Secretary Walker, to staff never get enough credit, but they are what make everything turn. So from DHSS and legislative staff, thank you so much. To Delaware Tech for hosting as well, for being very generous on so much short notice, opening up your doors and making it possible for people to get to a convenient location. Is extremely, extremely helpful and facilitate the conversation, so we thank you for that. And for those of you who are particularly geeky in the healthcare field, apparently, that's the criteria for October 18th meeting with regard to data analytics. You can see the gleam in Secretary Walker's eye when she said data analytics, so it sounds like that'll be a very, very fun show as well. So keep an eye. If you do what I do on a daily basis, which is Google DHSS benchmarking, just to stay on top of things, it'll take you right to their page, first link right there, and details about the meeting will be available, as well as you can send an email and sign up to get a notification on an ongoing basis. Thank you all very much for being here today. Echo Dr. Walker again, and thanking our guests from Massachusetts. If I had my way, every November would be a Cubs versus Red Sox World Series. And it seems like we're on a path perhaps to have that this year. So my home's open to you to come on down and watch my Cubs beat your Red Sox. That would be great. But we all know that, as Dr. Walker had said, moving forward, everyone in this room needs to continue to be in rooms to figure out how this is going to look once we sort of get past the general framework and have that kind of collaboration as a lot of people come together and think about things in a way different from how we've thought about it before. But the fiscal realities and the disparities on health among different populations are things that are not only unacceptable, but are no longer things that we can avoid. So we've got to figure this out, and it's fantastic to have a team at DHSS who's ramped up and ready to do that. Thank you all very, very much. Look forward to seeing you in the future. Thanks.